welcome back to another edition of the Heart to Heart podcast. And my guest today is Dr. Ira Price. So, Dr. Price wears a lot of hats. He's a sports medicine doctor. He's also an emergency medicine doctor. He's a cannabis doctor, has a lot of interest in psychedelics as well. So, he's a wealth of knowledge, and we're really happy to have you here. So, welcome to the show, Ira.
Hey, thanks so much for having me. It's great to be here. I love seeing you, bro.
I love seeing you too, man. It's definitely been a while since we connected, so it's good to see you. But yeah, before we get started and I start peppering you with some questions, just maybe give us a little bit more of a introduction than I just did.
I think you did a good job. I don't know. I do a whole lot of stuff, you know that. I don't know. I wouldn't know where to begin, to be honest. I think we've both been around the block a little bit. I sit here and watch you. That's what I do. I watch all your shit. It's awesome. I love watching you. I love seeing all the stuff that you're doing. Well, I think you said it. The only thing you left out maybe was coroner. I'm a coroner in the province. Yeah. Okay. But yeah, emergency medicine. That's what I did my specialty in for 5 years. And I did a fellowship in sports med. Back about a decade ago, I started working with cannabis in maybe 2010, and then sort of branched off from there, and then opened up a couple clinics, working in pain, doing research with cannabis, really just trying to figure out how we can get away from opioids and other narcotics. I mean, obviously there's a place for all that stuff, but anyway, just been working around. Trying to enjoy my family, my life, and make a difference in the world somehow, impact it, doing things that I love. It's really the ADHD. I'm like a poster child for attention deficit.
Well, it seems like you're able to focus all that energy on good things, all the time. So I think that you have a focused ADHD, and I think I'm sort of the same way. And I have a lot of different interests, and I don't think that's necessarily a bad thing. And I think it's worse when you have no interest and you get bored very easily. Whereas, for myself, like there's so many, things that I wish I knew more about just because, I'm interested in them. But at the same time, if you want to be so-called like an expert, sometimes you kind of have to narrow your kind of field down to a couple different areas and kind of just hone in on that. But, since you mentioned cannabis, why don't we kind of start there? So, I guess the main reason, or you kind of mentioned it already, but you just more or less felt like it was just a better alternative to a lot of the medicines that are being prescribed today, or what was the main got into it?
My main reason is there's a lot of emerge docs in the world. And if you want to impact something, like, I mean, there's some really smart folks out there, a lot smarter than I am. And so, as much as I love doing emergency medicine and I still work in it, if you to make the impact in the world, emergency medicine has a lot really bright people, and but there was nothing really happening in the area of cannabinoid medicine. There was some smart folks, but mostly all researchers. And I was frustrated, man. I was super frustrated seeing what was going on in the emergency department. Looking at our toolkit for the treatment of chronic pain, looking at seeing people coming in either overdose, dying, asking for more narcotics or acute withdrawal, and there's something else out there, just what it was at the time. And eventually it's funny, it was like at that time I had gotten a call from a good friend of mine. Like, these are people going back to the real, like back when advocacy for cannabis was really happening. I got a call from two friends of mine. One is a guy named Eagle and another guy named Ron. I'm sure people who are listening to this know who Ron Marzell is. He now lives in Colombia. But back in like the early, like I guess 2009, 2010, these were the big advocates, and they had come to me just randomly one day saying, do you know anybody that would be interested? Actually, they asked me if I knew a psychiatrist, and it was like, for what? And it was, well, we're trying to help people get off of certain drugs and all these mental health issues that they're talking about. And we need somebody to affirm, because back then it was like this big affirmation. You wrote filled out all these forms to sign for cannabis. And if I knew anybody, and I was like, well, hold on, you're talking about cannabis? back then they were still using marijuana, using all the words that we don't, weed, all the things we don't talk about anymore so much. And I'm like, hold on, look no further. Cannabis, probably back to that. But I really didn't know anything about it from a medical perspective. I mean, yeah, I had literally just finished residency, and I was so frustrated already. But then it brought me back to high school. I'm like, oh, okay, cannabis. I could figure this out. Marijuana. Oh, let's figure it out. But then I decided I also work in an academic center. And I'm like, if we're going to do this, it just can't be random. Right. But back then we had nobody. We didn't have, there was no Dr. Mike Hart's running around, like, educating people and, on clinical practice. We had researchers. We had guys like Mark Ware and Fiona Campbell and John Lynch, or no, sorry, Mary Lynch, John Clark. Those were like the four main humans in cannabis. Like you're talking about these juggernauts of research, but there were no clinicians really. And so nobody had any guidance for me at that time. So I basically said, if we're going to do this, we have to do it properly. And even those advocates hated me. I was hated by everybody. So they're like, what do you mean? Can't you just give us 30,000 grams each? And I'm like, no, we're going to create guidelines. So most of the stuff that everybody uses today was kind of created back when I started thinking about this is what we're going to do. And eventually it disseminated. But that's how I started. I mean, it started back in for medicine in Canada on like a big scale. It started basically when I did back in 2010, and I opened the first clinic.
That's sick. Yeah. What I mean, I
Fun.
didn't graduate till I didn't start practicing till 2013. I didn't start using cannabis till 2014. But similar to you, like I just sort
Yeah,
of
you did. You were using cannabis. Huh?
you
I'm
mean
just
personally? But I kind of had the same, idea that as you, as like, there's a lot of drugs that are being prescribed these days that I'm not saying are not effective and still don't have their use, but it's just that we can use cannabis sometimes in place of those drugs, or at least to reduce them. And like, I'm not, completely against opioids. Like I've said,
sure,
lots
of
of times that I think,
course.
we should be used in place of opioids, but in like acute settings, obviously sometimes, people still do need opioids. And in the long, and there's certain chronic pain patients, very, very few, but certain chronic pain patients probably do need opioids for life, unfortunately, just because of the
Yeah,
situation that they're in. But at the same time, as we know, and everyone I'm sure listens to this podcast knows, that opioids can cause respiratory depression, whereas cannabis doesn't cause respiratory depression. So overall, it's just a safer drug, a safer
yeah.
alternative. And
It
I
doesn't work
find
for. Oh, sorry.
I was gonna say, I find too, like for like sleep, I just feel like right now we still don't have like great medications for it. Meaning like trazodone and zopiclone are probably the two most common ones
Imavane. Yeah, exactly.
prescribed. And a lot of people just don't find them to be all that effective. So I think that when it comes to like insomnia, say, versus pain, like, yeah, opioids are effective, but they're also super addictive and can cause death.
Well, I'll tell you, like the
Look at
drugs.
insomnia, it's just that sometimes they're just not that effective, period.
Yeah, the drugs you just mentioned, none of them are meant for insomnia to be used on a long-term basis. I mean, Imavane is meant to be used for 10 days. Like that's like the max. And you got these people on it for years on end.
Mm-hmm.
And I mean, I don't actually use cannabis as a first line for sleep. It is helpful, of course. Actually, there's really good evidence for it now. A lot of evidence that is coming out of the United States that they can't publish, and I talk about it in a few minutes. But I mean, for sleep, for example, I start with obviously like the same way you do. When we talk about a holistic approach, I never see cannabis as the answer. I see it as a means to an end. Right? If you have a sleep issue, sleep is your issue. Cannabis isn't your solution. It's a means to help you sleep. But there are other things that can help you get there as well. Like if your brain is still functioning at full blast and you don't wear your blue blockers at night, or you're in front of blue light all day, and you haven't had your meditation, well, then you're going to have, or you've just drank like 5 cups of coffee, you're going to have more problems than just cannabis solving like giving you a solution to sleep. So like I tell people like, yeah, cannabis can help you, but why don't we start off with 10 minutes of meditation. If you can't do that, do it for a fucking minute, because God knows I can't meditate it. By the time, like, as soon as I stop thinking, my brain starts thinking. So like that's why I keep going, because if I stop, like all of a sudden the brain starts moving. So I try not to stop. But after like meditation, binaural beats has really good evidence as well. It throws different hertz in your ear, and you wear earphones, and like the meditation sounds you hear in like yoga studios or when you go for a massage. So those for the most part are binaural beats, but they're meant to be used with earphones because it throws different frequencies in your ear, in each ear, that enables your like brain waves to slow down and allows you to sleep a little better. So I literally start people with that. I see, like, how many people do I see in Emerge coming in, or even in clinic? I can't sleep. What have you done? Well, I cut out coffee past 8 p.m. All
It's
right.
a good start. But yeah, going back to your binaural beats, like I think those are extremely effective. Like I use them all the time. Like if I have to do any deep work or any like studying on something, like I always throw them on. Like there's just simple things you can get on like YouTube, like for free, where you just type in something like alpha wave brain states or something like that.
Exactly.
You'll get beats that come up that you can, and like you said too, I think it's like, yeah, you can get some benefit from using them like through like a speaker, but I think you get way more benefit when you use them through headphones.
Totally.
And I think that's definitely like an underutilized tool. And I haven't checked it in a couple of years, but I remember when I was researching them a little bit, I did see some stuff indicating that these alpha wave beats and theta wave beats can be effective for reducing anxiety and reducing some symptoms of PTSD. So it's kind of interesting that you brought that up, and that's probably something I should start chatting about a little bit more and maybe researching as well, because I'm sure there's been some new research that's come out on that recently.
Yeah, there's some good evidence. The reason it came to me was because I gave a talk in Florida. Shout out to those guys; they're awesome. At their first the Florida International Cannabis Conference, like literally March 2019, as COVID was starting. It was phenomenal. I was like getting on a plane. Actually, I was skiing when COVID started. And anyway, that's another story. I'm like, nah, it's gonna go nowhere. It was like zombie land when we left the mountains. But just before that, I was giving this lecture, and a friend of mine now out there, he's I think he was an ophthalmologist, but somehow he got into cannabis, and he was doing research in a sleep clinic on using cannabinoids for sleep, specifically around THC, CBD, and CBG, and 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 he was talking about alpha um, which other
Theta,
waves was he talking about? Alpha
theta,
waves, theta, maybe.
yeah, theta.
Yeah, alpha theta waves. And so, I mean, his findings were super interesting, specifically around REM, because what I used to believe was that you would have shorter REM, which is what we still think about PTSD. We thought that both THC and CBD work similar, in that they decrease your REM sleep, and that's where you dream heavily, so you have this decrease in PTSD. You don't have these night terrors that you usually get, which was the idea around what we knew about THC and cannabinoids around sleep. His research was super interesting. He says, no, you actually increase your REM sleep, but not in a single cycle. You pass through REM a lot quicker, but you get an extra cycle of REM in. So let's say you do 4 cycles or 5 cycles a night, whatever it is, you get an extra cycle of REM. It's just shorter duration. So in an 8-hour sleep, you're still getting the same amount of important sleep. You're just getting less at each cycle. So you were dreaming less, which was I thought that was pretty cool. So can't publish that.
That's really interesting. And one time I asked Dr. Ethan Russo about that, and he said that there's basically no reduction in REM sleep when you use THC. He didn't explain it to me in detail like that, but that's probably the reason why.
Yeah, Well, he has about 200,000 people in that study now, which is phenomenal. I mean, it may have just been data collection. I don't think he'll ever be able to publish it because of some legalities in the US. Still, maybe one day they'll be able to do it.
Yeah.
But it's pretty cool. So you spoke to Ethan Russo, huh? Wow. See,
No,
these are
no.
the
I mean, this was just on email, maybe like 2 or 3 years
okay.
ago. I just kind of asked him something, but I don't really know him that well. But I know that he's, considered to be definitely one of the godfathers of cannabis type of thing.
Certainly is.
But
Certainly is. Really nice human.
also too, just coming back to the sleep and like your approach for it. Like, do you have like a certain approach? Like, do you think people should just start off with CBD, like CBD, THC? How about CBN? Like, like, how do you sort of think that people should begin using cannabis for sleep?
So, I mean, obviously, like I had mentioned, cannabis to me isn't, it's not, hey, I haven't been able to sleep. Here's cannabis and try it. And are there certain, and what are the ratios that are helpful, and what are the terpenes involved? I actually do have an approach, and the approach is first do a proper history and physical examination and rule out underlying causes of 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 uh, of sleep disturbance, because there's primary and secondary, or, causes for it. So first we have to make sure there's no organic cause for sleep disturbance like sleep apnea, hypothyroid, hyperthyroid, or any of those other causes that may cause it. And then move into the underlying cause. You always need to treat the underlying cause, right? If it's a secondary, like, is there a PTSD involved? Was there a traumatic event? Is there increased stress in your life? Are all those things happening? And once you deal with all those, then let's see what happens. For me, if you're using cannabis um, as a supplement, and you see it as a supplement, I guess this comes into the theology of how we see cannabis. If it's a supplement and you just use it on a daily basis for health, fine. That's totally different than if you're using it as a treatment for something. If you're using it as a treatment for sleep because you haven't been able to sleep, there's a lot of things you can do before you move into an actual medicine. Like I mentioned, you start off with the coffee, you start off with your nutrition, you start off with the blue blockers, because getting rid of blue light at night is like probably 30% of the problems that I see.
Yeah,
Uh,
I wear big blue blockers every single night, and I keep them by my bed even if I have to go to the washroom.
that's right. It's a great idea. It was a good friend of mine that introduced me to those back probably a couple of years ago. Brian, probably see him a little bit around, and he was, dude, looks strange as a fool, but he wears these big ass blue blockers. I'm like, what are you doing? And that started to make sense to me because keeps us moving. So I start with that. Then I move to cannabinoids, and usually it's patients. It's so unfortunate that cannabis is still a last option instead of, or a last ditch, hope instead of a first option. And that's really unfortunate because cannabis can help so many different disease processes without having to rely on all these things like imovane and effexor or whatever, and other neuroleptics. So I help people get off of them usually it's a 1-to-1 ratio. The reason I use the 1-to-1 ratio for sleep is because that's what he did. And yeah, a THC to CBD. That's what he did in his study in the US. I looked at the data. I wish I could even mention the name. That's how crazy it is. I can't even mention the name. But you know, so I use a 1-to-1 ratio. And are there specific terpenes that can help with sleep? Beta carotene, we know, does help a little bit, but not very much. Usually a 1-to-1 ratio helps, and most of the time, to help people get to sleep, THC is great and CBD will help you stay asleep. That's kind of how they look at it, at least is what I've noticed from the data. And so that's basically what I do. But now how I start people, obviously that's a whole other story.
Okay, cool. Yeah, that's
That
well,
was
I mean,
complicated way around your answer. Sorry, bro.
no, it's a
I got
great
carried away on your hair.
it's a great answer. We can talk about my hair after too.
No, I like it. You got the shit. That's what I used to do, bro. I used to have my hair like that. You remember I shaved one side?
You
Actually,
did.
I basically think that was what my hair looked like.
Yeah, you. I think you need to go back to it, brother, because
I might try growing it again. I don't know if it'll grow anymore.
well, you got to try
COVID
it.
killed my roots. I don't
You
know.
got to try it, and then next time when you come on, I'm sure you're gonna have a full head of hair.
I hope so.
But getting back to the sleep thing,
Yeah,
yeah, like if someone is completely naive to cannabis, sometimes they do well just with CBD. It's not very many people. Like I
yeah,
remember I did a poll on it once, and it ended up being about 15%, which isn't a low number, but it's not a high number either. So it's not going to be definitely the most effective way for most people, and most people do use more of like a 1-to-1 ratio.
yeah,
And that's what I've seen too, is that THC can really help with the induction of sleep, but CBD sometimes can help you stay asleep a little bit better. The other one that I've used recently too is CBN, and a lot
yeah,
of people do find that that can also be sedating. So CBN, if you're not familiar, it's just another cannabinoid, just like THC and CBD is. And like I've discussed on this podcast before, we don't have commercial access to a lot of different cannabinoids out there, so I sort of hesitate like discussing them, like things like THCV, for example. Like the research is awesome, I wish I had access to it, but I don't know anyone who has access to it, so I kind of don't really talk about it. But I've talked about CBN a bit just because you can get that in Canada now. So if so I guess one of the messages that we're trying to get across is that if CBD doesn't work for you on its own, maybe try THC with CBD. If that doesn't work, you can also even try THC, CBD, and CBN, and see if that works. So, there's a lot of
yeah.
different ways.
Both of them shown. Yeah, I both of them. Are we still there?
Yeah, we're
I
still there.
lost you a sec. Oh no, you're there. Can you hear me? Okay.
We can hear you
Yeah,
okay.
so I think if we're going by pure evidence based, I think both of them have shown to be effective. But in the clinical setting, uh, you know, I think what I've found is usually a 1-to-1. But starting a naive patient, like you mentioned, is, I mean, it's never easy starting a naive patient. And when we say naive, I know we're talking about naive to cannabis, folks, not like naive in life. You naive asshole. Fuck you. No. Yeah. So yeah, starting low and following a protocol is always the right way to move.
Yeah.
Whatever you're doing with your patients, I'm sure is awesome.
Well, I'm certainly doing my best with them, and I think some of them are getting a lot better sleep. So, but
Yeah.
always looking for new research and new help from people like yourself to guide me. So appreciate all the input that you've given so far on that topic.
Yeah.
But
Thanks. Yeah.
also too, I know we're gonna chat a little bit about COVID, but it's I know that you have some interest too in general psychedelic medicines, and there's unfortunately it is still tricky at this point to prescribe them for the most part. I mean, I do quite a bit of ketamine, but as we know, ketamine technically is not a
Are you
psychedelic.
doing ketamine in your clinic?
I'm doing yeah, so I'm doing ketamine in my clinic as a monotherapy. So I have patients like take it at home, and they take it at home, and they've done really well. And then I've also have patients that only take it under the care of their psychologist, and then they have
So
a
you're
set.
not doing ketamine infusions or injections.
No, I'm not doing infusions.
Yeah,
So it
because
should be
that requires a level 2. I've looked into all that shit.
yeah, me too. It seems like it's quite difficult to do
Yeah.
and to implement. And then also too, luckily, I mean, I know most of the research online is on like IV and IM, particularly IV, but I've had just a ton of success with my patients using it orally. So I think that it can be used orally, like basically just as effectively as it can be IV for the most part. And I think
Hmm.
it's a medicine that we can definitely like use a little bit more in the future. And I think that more people are starting to kind of wake up to it and use it.
I really first Dr. Michelle Weiner out of Florida. I'm sure you know of her. She actually runs an IM ketamine clinic, which is phenomenal. She's great. If you haven't had her on your podcast, I'd really I'll give you I'll give you her connection.
Sure.
She's like she's certainly ahead of her time. Like we were doing with cannabis, with she's doing it with psychedelics out in Florida, and she's phenomenal. And she does a lot of ketamine. She's like 120 milligrams IM. and then does therapy and stuff. There's a lot of the evidence is mounting for it. Clearly,
Mhm.
it's still. I think there's probably more evidence for the use of psilocybin and LSD in lysergic acid in for the treatment of depression and mental health than there is currently for ketamine. But that's because they're a lot older. There's thousands of really good studies. There's certainly a lot more evidence for the use of psychedelics in mental health than there is for cannabis, and all of which have, and I know you're heavily involved. You've got your own companies that are running, I don't know, you're doing some functional mushroom stuff, which is pretty cool, and probably moving into that space. That's probably your way in, which is phenomenal. I personally believe that LSD is more effective than psilocybin, but less people study it. It certainly hits more receptors. There you go. Everybody wants to study it. You know, you have psilocybin hits like, 5H, your 2
5-HT2.
5HT2A, 2B, and a couple other receptors. But LSD hits all of them. And
Yeah.
then you can knock out the ones you want to with inhibitors or whatever else you want to do. Like, there's so many more options. I believe it's also easier to make. I think it's more dose controlled. So I think personally that LSD is 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 a future pharmaceutical
Yeah.
that will be, even socially responsible pharmaceutical. Um,
Yeah,
but
I agree with you on that. Just because, like, I think that a lot of the reason that it's really simple. I think the reason why people prefer psilocybin over LSD is because LSD is known as acid, and if you
right,
say acid, like that sounds like you're doing crack,
scares
right?
people,
Like
right?
acid sounds
Yeah.
like crack.
Well, we
Whereas
know you're a crackhead,
if you just say that you're doing mushrooms, it's
right?
like, oh,
Uh,
it's just kind of mushrooms, It
doesn't
sounds
sound bad.
like comes
It's so
from the ground.
true.
Like, how can it be so
Yeah,
bad? It's
yeah,
like acid, like it's crazy, right? So
yeah.
I think that's why. But like you said too, and you probably know a little bit more about this than I do, but like in the 60s and 70s when they were doing a lot of research on LSD, like they said that part of the reason why they're so disappointed now that research is stifled is that drug itself, because it hits so many receptors, can teach us about the brain and can teach us about mental health. Whereas other drugs that don't hit as many receptors, there's nothing really to kind of like unfold or to reveal about new teachings or new methods that we can help people with. But with LSD, it seems like it's like a pharmacology teacher.
It's a good point. It's funny if you read. I honestly can't remember even remember the name. I feel horrible right now because he is like the psychonaut of the century. Wrote a lot of the information that we know about it, and he's out in California. And I'm sorry, I can't remember his name off heart.
Not
And what's that?
Hoffman.
Not Hoffman. No, no, no. I can't remember. He's still around now. Nice guy. Anyway, one of the points that he made, and I'll have to remind you, I wrote this little primer for psychedelic medicine. I just haven't done anything with it yet. It's funny. I was going to be in, Sari. She did that psychedelic guide, the individual psychedelic guide. I actually wrote a forward for it. I never ended up using it, which was on the science of psychedelics. And but one thing that I remember from it was him saying that one of the reasons we now understand things like schizophrenia and the location of a lot of these diseases in our brain was from the study of LSD. That's specifically how we know. So it was a good, my point was you're just fucking smart and you raised a good point. That's all I'm trying to say. Okay.
Okay, brother, I got it. But also too, I want to keep asking you about LSD because
Why? Got to go
because
upstairs to my fridge. I'm just kidding.
because
I'm kidding, people.
psilocybin. I mean, psilocybin does have a bunch of different strains, so we're not saying that like psilocybin is
Right.
psilocybin kind of thing. But
Yeah. Yeah.
LSD seems to have it's even more different, or has even more of a variety of potential effects, and there's different analogs to it. And I don't know if you know too much about any research on that, or if there's like some new analogs that you've been studying or know about, that may be coming to the forefront in the future.
No, currently, I think the research. It's interesting. Most people are just doing research on psilocybin right now.
Yeah.
LSD has, the only group that I know of that was doing an LSD study was MindMed,
Okay.
and and I don't know what part of it they're studying right now. I don't. I know that I was about to start a research project in a specific, analog I can't talk about.
As a
But
participant?
yeah, no, yeah. Well, I mean, that's yeah, it starts upstairs. Then it leads into my backyard in the forest, and it ends in the swimming pool. Hopefully not. No. There are some projects that are being started currently on prologues, really, to or pro drugs to LSD, and seeing how those affect us in the future. I can't really go into too much detail on that, to be honest.
Yeah, and just to kind of like round out the psychedelic conversation, I mean, I don't really see, I haven't heard any rumblings anyway of like there being any introduction of anything like ayahuasca or DMT into the medical field. Like I hear people
Actually,
research, psilocybin a little bit on LSD, and I mean, you will find the occasional study on DMT online, but it's
yeah.
certainly not something that's like discussed in the medical field right now at
I'm
all.
I'm actually just looking right now to see if I can find this study. There's this ayahuasca study that was just done. But I don't I don't know where it was, and my phone is taking its time. Hold on. I have this database of all my studies, and there's thousands of them in here, and uh no, I don't know where it is. Anyway, there are some studies, but not too much, not too many. To be honest, they all hit very similar receptors. And they all work on very similar areas of the brain. That's why when you do, like, even when you're writing the experience might be different, and if it depends how we hit it. If we hit it from a purely scientific way, it's like saying, THC is THC. Same idea. They're all hitting the CB1 receptor somehow, and they're all blocking, and CBD is all blocking it or whatever. But the experience of each different chemovar is very different when you have the clinical experience, right? So
Mhm.
if you look at psychedelics, they're very similar like that. A lot of them hit X and Y receptor, and then some hit X, TUVW, W, X, Y, and Z receptor. Right? I had to do that on my hand. You become dumb when you go into medicine. You drop 15% of your IQ. I learned that.
I think it's just you have to remember so much crap that you just forget a
It's
bunch
so
of.
true. Yeah, it's totally true. So some of them hit, but all together, when you look at psychedelics, for the most part, they're all hitting the same receptors. Some just have higher affinity. Some hit one and another, and a close receptor. Some just hit more, and I find that LSD hits all of them.
Okay. And last question on again, it's ketamine is not a psychedelic, but do
No,
you
it's not.
do you administer ketamine for patients in the ER?
I use ketamine every single day.
You do.
I
And what
think
do you
ketamine is I hate to say that it's an amazing drug, but it's a great dissociative drug that also has analgesic properties. So, and not many of our conscious sedating or procedural sedation, we've moved away and emerged from calling it conscious sedation, because a lot of times people, they're not conscious, they're procedurally sedated, but we use it all the time. And it does a great job of dissociating, and it does a great job at pain, and it's also hemodynamically stable, which means it doesn't really affect your blood pressure or heart rate in the average person, and it's great for kids. Now, there are reasons that you don't want to use ketamine. For example, if somebody is already on a TCA tricyclic antidepressant, or has a heart condition, or they're old, it could drop. It releases all what's called your cardiac catecholamines. So it releases all these chemicals in your heart that can deplete all of them, so you can't mount a sympathetic response, or a response that causes your heart rate to go up. So if you give it to people who are older, who have a lot of comorbidities, or are on a tricyclic antidepressant, which you have to be careful about, they can end up dropping their pressure and their heart rate, and then not be responsive to the medicines that we try to give them in return. So to bring back their heart rate and all that other stuff. So, but I use it literally for conscious sedation or procedural sedation on a daily basis. And emerge, I'll be using it tonight.
do you ever use it for just like someone comes in?
Recreation? No.
But if someone comes in, they're in like a very poor mental state, like they're suicidal or they're just very depressed. Like, do you ever use it and emerge in that way?
No, mostly that's not really an emergency. In an emergency setting, we would never use ketamine. Ketamine, if you're using ketamine assisted psychotherapy or anything like that, the guidelines for it is it's pretty intense. You have to have tried a couple other drugs first, and then the psychotherapy has to be ongoing, and it's nothing we have time for in the emergency department. People that come in like that, we usually either I'll keep them in the hospital if they're a harm to themselves or somebody else, or I'll send them home with an outpatient referral. The 5 minutes we get with them in emerge, which makes it difficult, doesn't allow, it's not conducive to using ketamine for that. We'll use it for like asthmatics though. It's a broncho, it helps bronchodilate as well as, or it doesn't cause respiratory depression, I should say, and allows us to treat asthmatics.
Okay, so being an emerge doc, obviously I got to ask you now, like, what's been your experience recently
Do
with
you have to ask
medical?
me?
I do have to ask you because people want to know the answer to this. They want to know what a real emerge doc is seeing in the hospital right now. So are you seeing a
I've
ton
already been kicked out of every doctor group I know.
are, are
They
you,
literally asked me, we don't want to deal with these questions here, Ira. Go make your own forum.
well, I guess you're gonna have to answer them one more time on this one
uh,
here. But are you seeing a lot of COVID patients right now or
no, I'm
no?
not seeing any. I never saw very many.
No?
We, I mean, uh,
You don't
are
have
you
to
trapping me?
you don't
I'm
have
just
to
kidding.
answer anything you
I'll
don't
answer.
want to.
No, of course not. I'll answer whatever you want. Um, so COVID, we'll start off by saying COVID is real. We know that COVID exists. Was our emergency department visits during the COVID period had decreased by 25 to 50%. Our departments were empty for 2 years, basically. Uh, Patients we did see were COVID. I saw maybe, sometimes between 2 to 4 COVID patients per shift that I was on, which means, and I'm one doctor of 8 in a day. So, sometimes they would have seen whatever 8 times 8 works out to be, and or 8 times 5. You know what I mean? So
That's
like,
40.
good job. Oh, we gotta open our minds. It's microdose. It's upstairs. The so so COVID, we at the I would say at the peak of COVID, I maybe saw the most I ever saw in one of my own shifts was 5 COVID patients per day, some of whom I've intubated. Like we would have to, resuscitate sometimes between 2 to 5 per day at the absolute peak. The department was still empty, and but COVID was coming into the hospital. I don't want to minimize that, but was it coming in to the point that we were overwhelmed and emerged? No, our departments were empty. Now that we're out of this third wave, COVID is, I mean, our departments are packed, like literally like jammed with people that didn't come to the hospital for 2 years. Talking about 10-hour wait times in the emergency department because there's no beds anywhere in the hospital, but there's no COVID in the hospital. They're just packed with normal shit, like they've always been packed with.
So what are they
Except now we're
like?
packed
And
with people
again,
that didn't come to the hospital for 2 years. I've had a heart condition for 2 years. I didn't come in because whatever. I had a gallbladder problem. I didn't come in because whatever. Oh, my mom and dad are declining, and I didn't want to bring them in for 2 years or a year because of COVID and etc. All these things. I think the fear that has been imposed on the population has created such a taken such a toll on society that we're not going to get over that for years and years and years and years to come, and we're seeing it in the emergency departments now. So did we have COVID in the hospital? Yeah. Were the emergency departments overwhelmed? Not at all. uh were the ICUs packed? Sure, they were busy. Yes, if I was an ICU doc, I would think the whole world was falling apart, but they also don't go outside. I'm an emerge doc. Do I think everybody's dying of a heart attack? No, but that's because that's reality. That's confirmation bias,
yeah.
right? So we have to just be very careful with how we interpret data sets.
And right now, are you finding that there's people coming in with a lot of adverse reactions from the vaccine or not so much?
So again, I'm going to preface this by saying that I think there's over 2 billion people in the world that have been vaccinated. and the death toll of these 2 billion people isn't rising disproportionately to any other normal death rate that we have. So the vaccines for the most part are safe for most of the population. And when there are side effects, there are side effects that are that for the most part are minimal. I mean, I wasn't one. I had a horrible side effect to it, I was one of 22.5 million people who had what I had, and at the time that I had it, but for the most part, they're effective for most of the population. We see that now, and so the COVID that I am seeing, like the 1-2 people come in like in a day or in a week, we don't see very many, are usually unvaccinated. For the most part, their symptoms or the symptoms of those who are vaccinated are very, very mild, and they don't show up to the emerge. So when it comes to vaccination side effects, there are side effects. There certainly are, and I don't think we can deny that. There are physicians who don't want to admit it, but that's their problem. The truth is, it's there, and we know they're there. We're not overwhelmed with that in any way, but you do see, 1 or 2 a day that come in with side effects. Certainly, I've seen, nothing. I've seen really bad all the way to stroke and
Okay.
blood clotting to I have a cold and I have myalgias. And for the most part, most people are cold and myalgia.
So, and I just want to ask you too about, so like, you said that most people who are vaccinated do get less severe symptoms than people who are unvaccinated, correct? And
Yes.
and I saw too that I've been looking for this data for a long time, and I saw that Dr. Jennifer Kwan, I'm not sure if you follow her on Twitter, but she's kind of been like the stats person with COVID that I followed the most, and she seems to have really good and up to date statistics. But it wasn't until yesterday that she had some statistics on
It's
how
funny.
many people
Yesterday, it all came out.
yeah, I like on how many people were coming in unvaccinated versus vaccinated. And it was basically between about 95 to 97% of the patients that she said that had they either were infected with COVID or hospitalized or died from COVID were from unvaccinated people, right? So that would indicate that the vaccine would be, incredibly effective. And I'm not saying that it's not effective. I do. The only thing that I'm just like confused about, and I don't know if you have any insight on this, is that like if you look at the number of people, the cases that are in the emerge now, and the number of cases that Ontario is seeing, it's like the exact same as it was last year this time. I
Yeah.
mean, in some days it's even less.
Yes.
I don't like how do we explain that last year during this time without the vaccine, we had the exact same numbers that we have here today with the vaccine. Like that's something that's a little bit puzzling, I find.
Yeah. No. I mean, clearly, it's cyclical and it's seasonal, right? We're going to see a spike in the fall, and the question is, but remember, we're just looking at Ontario or Canada. Look at
Mhm.
other countries where it's not winter or where it's not summer right now. Look at
Yeah.
countries where it's winter right now or where it's summer all year round, and look at their numbers. So don't we can't just look at Ontario and say, hey, this is super seasonal because look, it's summer and everybody's outside, so our numbers are down. Well, let's look at other places and see what their experiences are, and where they're seeing the spike. I look at somewhere even like Israel. They're seeing a spike in their numbers, but all of the people going in, and it's summer over there. It's really hot over there, and their numbers are still going up. We have to look at that data set, of course, and how we interpret that data set. Can't just say, oh, look, everybody's still getting COVID and they're all vaccinated. Well, they're still case counting, which, I mean, case counting may be ridiculous once you're vaccinated. If you trust your vaccine, why are we case counting anymore once your population is mostly vaccinated? But most of those people aren't going to the hospital. The ones who are going to the hospital are those who are unvaccinated. Listen, I'm not a proponent of lockdowns. We know that they don't work in the sense that they cause more harm in other areas. It's always a risk benefit ratio that we have to weigh. The risk, do lockdowns stop COVID? Sure, they stop. I mean, if I stayed at home and did nothing all day and didn't leave my house, I wouldn't be able to transmit COVID. I think that's the logic behind it. But if I do that, I may wind up killing myself and overdosing on a narcotic. And then my kid's going to have to go to the hospital because they're also suicidal and they're only 6 years old. And so those risks and benefit, and I can give you all the numbers for how that kind of thing played out, the benefit of lockdowns don't work. But vaccinations certainly are working, specifically looking at the 2 billion people in the world that have been vaccinated. Is it seasonal? For sure. It's going to be seasonal like the flu, and it's going to eventually be part of just another swab one day. I don't know when that's going to happen. When you get your NPS and you go to the hospital because they think you have the flu and you're going to get swabbed, COVID will just be one of them. Hopefully that's someday soon, that it's no longer considered a pandemic. But honestly, we're going to go through, I believe I mean, I hate saying it, we're going to go through a fourth wave coming, whatever that means. I mean, I hate saying the word. What does the wave mean? Like, why do we care so much about it? It's going to be the unvaccinated. We know that it is. We're seeing it all around the world where it's not summer anymore. And I mean, but does COVID kill people? I think the question comes down to, like, it's a tough question because we're still living in a democracy. I don't fight for um I don't say that, you have to get vaccinated. I believe in vaccination because I've seen it work. But at the same time, where we live in this world of the fallibility of democracy, where if you don't do something, yeah, it's your right not to do it, but it's not. We don't really live in a true democracy because nobody's asking us if we want to do something, do it or don't. So the fallibility that we live in is really, I think, what's irking people the most, not the idea of vaccination. If doctors approached this in a different way and didn't just say, here, take this, go home, or you die, we probably wouldn't have the problem we're at right now. Data is confusing, right? If I look, data is very confusing. And science data, if I'm going off, you stop me anytime, Mike.
No, go. It's
But,
okay. I have something to ask you, but I want you to finish this point.
Okay, my point is data is confusing. And scientific data is even more confusing. Why? Because it changes constantly. And if you're on the outside and haven't been in medicine for 2 decades, or don't know how to, or just learning now how to read data sets, scientific data sets, you'd be like, what the fuck is everybody talking about? Why are they saying this and then they're saying that and saying no? Well, let me give you another example. Let's talk about ACLS, advanced cardiac life support. Let's talk about resuscitation.
I just want to ask you one quick question though.
Yeah.
So the unvaccinated people that are coming into the hospital, are these healthy unvaccinated people, or for the most part are these people who have comorbidities and tend to be
healthy people?
Healthy people.
Healthy people. Yeah, it's mostly younger people, because most of the older people, over 80% of that population, is vaccinated. You don't see older people really coming in anymore with COVID. I mean, they come in with their community acquired pneumonia that's not COVID, back to their usual experience. But the people that are coming in are usually younger with very minimal comorbidities.
And I know you don't believe in medical coercion or anything like that, but like, do you feel that everyone and you don't have to answer this pinpointly, but like, do you think everyone above the age of 25 should get it, everyone above the age of 18? Like, do you feel like it's
I don't have a good answer for that. I think that we have a dual responsibility in society. We have a responsibility to ourselves and our family, and we have a responsibility for a vested interest in the health and safety of society in general, for us, in order for us to progress as a society. I come at it from a very pragmatic way, I think, a little bit. And that's, my wife also owns a business, and I want her business to remain open. And the way that businesses remain open is if we have a healthy society and our economy can move forward with a healthy society. There's no doubt that there were sick people coming into the hospital, but COVID doesn't kill all that many people. We're going to say it kills 99.8% of people are going to survive, as long as they're not your friends. The 0.2% of society that dies, you're fine with, as long as it's not 1 out of 10 or 1 out of 11 of your friends. Because once it's the 1 out of 11 of your friends, and there's like, hit home. If you have 10 friends that have COVID, or let's say 12 friends that have COVID, one of them is likely going to die in your little friend group, because that's the statistic. So as long as it's not your friend, you don't care. That's how we work as human beings. The human psyche is built to dissociate itself from evidence that's not ours. For example, if you see one person die, you're like, oh my God, that's one person. But if you see 10, if I say 10 million people died, you'd be like, okay, 10 million people died. It's because we don't understand it. Our human psyche is not built that way. So as long as it's not one of your friends, it doesn't matter. And that's where I like what that guy, dog, whatever his name is, on social media.
What's his name?
That doctor,
Um,
the he the dog something or other, whatever the hell his name is. I don't know. I watch his Ziggy, whatever. I don't remember his name,
I
but
don't think I'm familiar with this guy.
yeah, you are. I always post his shit.
Okay.
Anyway, whatever he said, Z Dog. That's it. That's I like what he said. COVID's not all that bad, yet it's terrible. Because it's not all that bad. 99.8% of people are going to survive unless it's one of your friends. You know, like,
Okay.
and then it becomes shitty.
And what do you think? I know this is super controversial, and there's some evidence today that certainly said that it wasn't effective. But what do you think of ivermectin?
Yeah, so I actually evidence came out today that I didn't see.
There was a Cochrane review that came out today, and they basically said that there was like low quality evidence, and that they're not recommending ivermectin at this point. And I'm not like dismissing Cochrane reviews, but a lot of Cochrane reviews are like, it's just such a stingy publication. Like,
Yeah,
it's
it
really,
is, but it is like one of our best sources for meta-analyses and stuff. But so my thought on ivermectin is, there's some really good high quality evidence from some randomized controlled trials that haven't had to be withdrawn because of bias, showing that it was effective. Is there, I think at the end of the day, it comes down to it comes down to how we see ourselves within medicine as a physician, and what we see our role is to society. Is our role to protect society and help them, or is our role to find the evidence and wait until we have the evidence? I kind of find it like there was that um, analogy in the Bible somewhere with the dude on the boat and getting eaten by a whale. What was that guy? Jonah, I think it was. And I
I
don't know.
don't know.
I don't
Unfortunately,
really
I don't know
know
much
much of
about
I don't really
politics.
know much of the Bible, but well, I mean, I guess actually I do. I came from a very religious background. So I know the Bible actually, funny enough. So anyway, I don't remember the whole story, but the story goes like this. Dude's on the boat, the rain comes, and then like all these like life-saving things are there, but like he just doesn't take any of them. He's waiting literally for the hand of fucking God to come down and grab him from this sinking ship, and eventually he's eaten by a whale. So my point to that is, if you're drowning and somebody throws you a fucking lifesaver, and it may not be a perfect lifesaver, and it may only be like half broken, but it's still floating, are you going to take it, or are you going to damn drown? Are you going to wait till you drown, or just grab it, take a hold of it? The harm is so low that you might as well, right? So like either you're going to die drowning, or you might as well take a chance if you're sick. So that's
Yeah.
kind of how I feel about ivermectin.
Yeah,
And
that's the way I feel about it too. I feel like it's okay, sure, that we might not have the best quality evidence that it helps. We certainly do have, a lot. And the other thing is that if you do take it, like the side effects are so minimal, there's virtually zero drug interaction. So it's like there's no real harm in taking it other than maybe you're creating a little bit of like false hope in the person.
right.
But there's really
So
no
let
harm.
me compare it. Let's compare that to how the mainstream physician reads the evidence around dexamethasone. So there was a study that came out looking at it may be pre-publication, looking at 6 or 12 milligrams of dexamethasone. And I know this because it was a conversation. I get kicked out of these convos, but like I stick around to listen to some of the evidence that they throw out. And so they're looking at 6 to 12 milligrams. We know that steroids are helpful in severe COVID cases. So the evidence is that there's really no major difference between 6 and 12 milligrams of Dex, of whatever steroid. But there was a lean towards survival rates being higher, non-statistically significant in the 12 milligram group. So the comments are, well, we should be giving 12 milligrams because, it may not be statistically significant, but there was a lean towards, this idea, even though it
Mhm.
wasn't statistically significant. So why is that okay? Why are we okay? Oh, because it's Dex, or because it's a steroid and we're happy with it, or you did the research for it and therefore you want to get your name out there, and it makes you happy, and you're just not happy with something like ivermectin. That's still same idea. Maybe it doesn't have the statistical significance, but there's definitely a lean towards it, whether it's moderate or low quality evidence. And I bring this back to where you cut me off before, when I'm talking about ACLS. If we look at like the evidence around anything we do in resuscitation, for the most part, aside from CPR, the evidence is low, but we still do it. We still
Yeah.
give epi, we still give amio, we still give calcium, we still give all these things. And the evidence for most of these things is very low.
I had a
And
Murdoch tell me that yesterday, but sorry, go ahead.
yeah, so, but we still, what? Tell what I just said.
Yeah, yeah, it's really strange to have this conversation because because I brought up ivermectin to him, and he said, you know, it's funny because he was in Emerge the other day, and he was giving someone epinephrine, and he said, there's really very little evidence for this, but everyone just gives it all the time without any question.
That's right. We do it all the time. 70% of the drugs we give to pediatrics are off label, but somehow we're okay with that. So this comes to our own biases in medicine, and we have to. And uh you posted something today that was awesome. I actually read it. I think it was you that said you have to look at the opposite opinion in order to
Yeah,
understand your own. I totally agree with that, and I think that medicine, I think us in medicine, if we want to do and really make a difference in people's lives, we have to see past our own confirmation bias. And confirmation bias, in my mind, is the big inhibitor of the progression of society.
I agree. I agree. And I really hate to do this, Ara, but somehow an hour has basically already passed. So,
Damn.
can you let everyone know where they can find you online, and your website, and the services you provide and all that type of stuff?
Yeah, check out Dr. Ira Price on Instagram. That's mostly where I am. I pretty much hide around Instagram. I'm on Twitter, but I don't really use Twitter all that much. I know I should, but honestly, I have the bandwidth, like, of all the shit that I do, I can't go back and forth. So yeah, just find me on Dr. Ira Price on Instagram. I haven't been doing my podcast in a long time, but it's on its way back. The Higher Estate, you can listen to it. I've had some really fun people on there in the past. Haven't done it in about a year, maybe
Right
more,
on.
since COVID. Anyway, I appreciate you having me on, bro.
Well, I really appreciate you coming on. You shared a lot of awesome information today, and I'm sure people are gonna be requesting for you to come back on. So, thanks again for coming on, Ira.
Thank you. See ya.